decrease reuptake of GABA. The epilepsy is because of repeated firing of the excitatory neurons. Basically, every organ has excitatory potential, it has inhibitory potential, but both the excitatory and inhibitory, they remain in harmony. The moment there is abnormality, disbalance leads to a pathological condition. In this case, we are talking about repeated firing of excitatory neurons. That is why we have drugs which is going to enhance the activity of inhibitory neurons. So let us start our topic with a small introduction video of epilepsy.
Epilepsy is a group of neurological diseases characterized by recurrent seizures. Seizures happen as a result of a sudden surge in the brain's electrical activities. Depending on which part of the brain is affected, a seizure may manifest as loss of awareness, unusual behaviors or sensations, uncontrollable movements, or a loss of consciousness. The brain is a complex network of billions of neurons. Neurons can be excitatory or inhibitory. Excitatory neurons stimulate others to fire action potentials and transmit electrical messages, while inhibitory neurons suppress this process, preventing excessive firing. A balance between excitation and inhibition is essential for normal brain functions. In epilepsy, there is an upregulation of excitation and, or downregulation of inhibition, causing lots of neurons to fire synchronously at the same time. If this abnormal electrical surge happens within a limited area of the brain, it causes partial or focal seizures. If the entire brain is involved, generalized seizures will result. Partial seizures subdivide further to simple partial. Depending on the affected brain area, patients may have unusual feelings, strange sensations or uncontrollable, jerky movements, but remain conscious and aware of the surroundings. Complex partial seizure, on the other hand, involves a loss or changes in consciousness, awareness, and responsiveness. Generalized seizures subdivide further to absence seizures. This type occurs most often in children, and is characterized by a very brief loss of awareness, commonly manifested as a blank stare, with or without subtle body movements such as eye blinking or lip smacking. People with absence seizures may not be aware that something is wrong for years. Tonic seizures are associated with stiffening of muscles and may cause the person to fall. Atonic seizures, also known as drop attacks, are characterized by a sudden loss of muscle tone, which may cause the person to collapse or drop down. Clonic seizures are associated with rhythmic, jerking muscle movements. Clonic seizures are rare. Myoclonic seizures are brief jerks, or twitches, of a muscle, or a group of muscles. There can be one or many non-rhythmic twitches occurring within a couple of seconds. The most common, and also most dramatic, are tonic-clonic seizures, also known as convulsive seizures, which are combinations of muscle stiffening and jerking. This type is what most people relate to when they think of a seizure. It also involves sudden loss of consciousness, and sometimes loss of bladder control. A tonic-clonic seizure that lasts longer than 5 minutes requires immediate medical treatment. Epilepsy may develop as a result of a brain injury, tumor, stroke, previous infection or birth defect. Generalized seizures that start in childhood are likely to involve genetic factors. Epilepsy due to a single gene mutation is rare. More often, an interaction of multiple genes and environmental factors is responsible. Hundreds of genes have been implicated. Examples include genes encoding for GABA receptors, major components of the inhibitory circuit, and ion channels. Many genetic disorders that cause brain abnormalities or metabolic conditions have epilepsy as a primary symptom. The cause of epilepsy is unknown in about half of cases. Diagnosis is based on observation of symptoms, medical history, and an electroencephalogram, or EEG, to look for abnormal brain waves. An EEG may also help in differentiating between partial and generalized seizures. Genetic testing may be helpful when genetic factors are suspected. There is no cure for epilepsy, but various treatments are available to control seizures. Medication successfully controls seizures for about 70% of cases. Many anti-epileptic drugs are available which target sodium channels, GABA receptors, and other components involved in neuron communication. Different medicines help with different types of seizures. Patients may need to try several drugs to find the most suitable. Diet. A ketogenic diet has been shown to reduce or prevent seizures in many children whose seizures could not be controlled with medication. Ketogenic diet is a special high-fat, low-carbohydrate diet that must be prescribed and followed strictly. With this diet, the body uses fat as the major source of energy instead of carbohydrates. The reason why this helps control epilepsy is unclear. Nerve stimulation therapies such as vagus nerve stimulation, in which a device placed under the skin is programmed to stimulate the vagus nerve at a certain rate. The device acts as a pacemaker for the brain. The underlying mechanism is poorly understood, but it has been shown to reduce seizures significantly. Finally, a surgery may be performed to remove part of the brain that causes seizure. This is usually done when tests show that seizures are originated from a small area that does not have any vital function.
So that was a small introductory video on epilepsy. In the video, we observed that there was abnormal electrical activity in the brain, which has led to epilepsy. If the same kind of abnormal electrical activity happens in the heart, what is it called? Anyone?
Arrhythmia.
Sorry?
Arrhythmia.
Yes, very good. So basically we are talking about the same etiology at different site. If it occurs in the brain, we call it epilepsy. If it occurs in the heart, we call it arrhythmia. And in fact, the drugs that are used for management of arrhythmia and epilepsy have the same mechanism of action. But the drugs which act on the brain have to be lipid soluble, that's why they are different, and the drugs which act on the heart does not have to be lipid soluble, so they are different. The mechanism of action of both anti-epileptic drugs or anti-arrhythmic drug is prolongation of inactivated sodium channel. In other words, you can even round up the sentence like prevent recovery of sodium channel. So basically, whether you study epilepsy or whether you study arrhythmia, the drugs that you will be studying may be different, but their mechanism of action are the same. Epilepsy has different terms. We can call it convulsions, we can call it seizures, depending upon the word of origin or where people find it comfortable to use any of these words. But they all mean the same: epilepsy, convulsions, or seizures. All of this happens because of excess electrical activity, abnormal generation of action potential in the neurons of the brain. So our target will be to decrease the generation of action potential in the brain, either by blocking the sodium channels or by enhancing the activity of inhibitory neurons like GABA. The reason why epilepsy occurs is because there is a loss of balance between the excitatory neurons like the glutamate releasing neurons and the inhibitory neurons like the GABA. There are three types of epilepsy. One is generalized, which consists of tonic-clonic, myoclonic, absence seizure, and the next is focal seizure or partial seizure, which is further subdivided into simple and complex. And then we have status epilepticus. Why status epilepticus is a separate category? Because this status epilepticus they last for a long period of time, while other seizures they last for 2 to 5 minutes, 10 minutes. This status epilepticus they last for almost 30 minutes. It is life threatening and at the same time it requires immediate management. The person can injure himself or he can injure the person around him also. That is why status epilepticus is a different category. In fact, sometimes the university question is write down the management of status epilepticus, because that includes almost all the drugs that you will be studying in the classification of epilepsy. Generalized seizure or epilepsy is when there is involvement of both the hemisphere of the brain along with loss of consciousness. In all types of generalized epilepsy, there is convulsions, tonic, tonic contractions, except for one condition, that is absence seizure, in which there is no movement. In fact, the person who suffers from absence seizure, like you saw in the video, remains still in one posture, looking at the sky above. Because this absence seizure is completely different from the rest of the generalized epilepsy, the drug that is used for absence seizure is particular. Basically, we give ethosuximide for absence seizure. However, we can also give valproic acid depending upon the age category. For smaller age group or children, we prefer ethosuximide. For age group of above 16 years or older years, we prefer valproic acid. Partial seizure, like we talked before, is again of two types, simple and complex. In partial seizure, there is generally no loss of consciousness, but there is some kind of CNS disturbances. Status epilepticus, medical emergency that requires immediate attention, includes almost all of the drugs that you study in epilepsy. It includes sedative and hypnotics, as well as it includes some general anesthetics also. So this one diagnosis, that is status epilepticus, will include antiepileptic drugs, sedative hypnotics and general anesthesia combined together. That is why it can be asked as a long question. Classification of antiepileptic drugs. Hydantoin consists of two drugs, phenylaltoin as phosphenoltoin. Now, if you see the second drug, phosphenoltoin, it resembles to that of phenylaltoin only. But whenever you find a drug whose name resembles to the parent drug, what you should understand is the parent drug is toxic. Like in number 3, aminostilbene, you have carbamazepine and oxcarbamazepine. Here, oxcarbamazepine is less toxic than carbamazepine. Similarly, phosphenoltoin is less toxic than phenylaltoin. Just give me a minute, okay? I need to receive a call. Hello? The reuptake of GABA. So more of GABA is available around the GABA receptors, enhancing the GABA activity, which is inhibition of generation of action potential. In short, and including almost all the drugs, sedative and hypnotic group of drugs, which includes benzodiazepine and barbiturates. In barbiturates, specifically phenobarbital. Both these sedative and hypnotic group of drugs, they enhance the GABA activity. Benzodiazepine only facilitate, whereas phenobarbital can facilitate as well as mimic the GABA activity. Ultimately is the enhanced GABA activity. Similarly, antiepileptic drugs like valproic acid, vigabatrin, gabapentin, and tigagrelin, they also enhance the GABA activity, but through a different mechanism. Valproic acid enhances the synthesis and inhibits the breakdown, whereas vigabatrin inhibits the breakdown. Gabapentin enhances the release, and tigagrelin-like drugs, they prevent the uptake of GABA. So, name it whichever drug it is, their basic role is to enhance the activity of GABA. This GABA, upon binding to the GABA receptor, produces opening of chloride channel, which leads to influx of chloride ion. We know that the chloride ion is negatively charged. So when a cell becomes negative, it cannot get excited. The state is known as hyperpolarized state. And in order to excite or generate an action potential in a highly negative cell, we need a very strong stimulus. That is how these drugs, they act as antiepileptic drugs. They make the cell hyperpolarize. We'll start with the first drug, phenylaltoin. It has to be toxic because we have another compound that is phosphenoltoin. So we'll talk about the mechanism of action and we'll talk about the adverse drug reaction. Sodium channel. Voltage gated sodium channel are available in 3 different states. One is the resting, next is active or open state, and the third is inactive or refractory state. Whether you say antiarrhythmic drugs or whether you say antiepileptic drugs, all of them, they prolong the inactive or refractory state of sodium channel. But the story does not end over here. Can anyone give me an example of another group of drugs which act in the same refractory state of sodium channel? Anyone? Anyone? Can you people hear me or the net has disconnected? Say yes or no.
Yes, sir.
Okay. So the another group of drug is local anesthetic. So I am bringing another chapter over here. Local anesthetic like lignocaine, bupivacaine, they also show the same mechanism of action. That is, they prolong the refractory state of the sodium channel. That is how these local anesthetics like drugs, they inhibit the generation of action potential. So here we have three different group of drugs having the same mechanism of action. Local anesthetic also inhibit sodium channel and produce anesthesia. Antiarrhythmic drugs class 1, they also block the sodium channel and produce antiarrhythmic action. And now antiepileptic drugs, they also block the sodium channel and produce antiepileptic action. So the same mechanism, just different group of drugs. So phenytoin, valproic acid and other drugs, they all of them, they prolong the refractory state. They prevent the recovery of the sodium channel from this refractory state to resting state. Because if the sodium channel returns from refractory to the resting state, there will be generation of another action potential, which is something we do not want. So the mechanism of action of phenytoin is prolongation of inactivated state of sodium channel, prevent recovery of inactivated sodium channel to the resting state. Whichever you find it comfortable, you can write it down. So by doing this, it stabilizes the membrane potential and prevent generation as well as transmission of action potential. Now here we have another video showing the different state of sodium channels.
Partial onset seizures, otherwise known as focal seizures, remain a treatment challenge for some patients despite a number of therapeutic options. Thus, there is substantial need for additional anti-epileptic drugs. The inhibition of voltage-gated sodium channels is a mechanism by which a number of anti-epileptic drugs may work. Sodium channels are key proteins involved in action potential firing in most excitable cells, mediating the transport of electrical activity through the brain. Neural impulses are conducted by the opening and closing of sodium and other voltage-gated ion channels, which regulate neuron excitability by allowing passage of ions across the cell membrane. Sodium channels are closed in the resting state. With mild membrane depolarization, the sodium channel opens, allowing an influx of sodium. As the intracellular concentration of positive ions increases, the inactivation particle quickly closes the channel, stopping the inward flow of sodium. The sodium channel is now inactivated and remains unavailable until the cell membrane potential repolarizes. Recovery from inactivation allows the sodium channel to participate in the next action potential. A sustained succession of rapidly occurring action potentials may spread to involve surrounding neurons, which may trigger an epileptic seizure. One type of sodium channel blockade modulates repetitive neuron firing by prolonging the inactivated state of a depolarized sodium channel.
Antiepileptic drugs like phenytoin have high plasma protein binding capacity. They are lipid soluble, but at the same time they have high plasma protein binding. Now, when a drug is plasma protein bound, somebody's mic is on. Whose mic is on? Naman Sharma, your mic is on. Naman Sharma. So we were talking about pharmacokinetic parameters of phenytoin. These drugs, they have to reach the brain, so they are lipid soluble. But at the same time, they are also highly plasma protein bound. Now, when a drug becomes plasma protein bound, it tends to behave like an antigen. And when it behaves like an antigen, it generates antibodies. It leads to hypersensitivity reaction. So this is the significance of high plasma protein binding capacity of the phenytoin, that it leads to hypersensitivity reaction. Another feature of phenytoin, or say most of the anti-epileptic drugs, whether it is phenytoin, whether it is carbamazepine, or whether it is phenobarbital, blindly, and even don't have to memorize, simply write down enzyme induction, cytochrome P450 enzyme induction, which means that it can have lots of drug interaction. It can enhance the metabolism of oral contraceptive pills, warfarin, theophylline, and sometimes of itself only. So there is variation in its own half-life because it enhances or increases the metabolism of itself. So drugs like phenytoin, carbamazepine, although they are not that much frequently used, they are important because of their adverse drug reaction. Like we said, phenytoin or any other antiepileptic drugs, if it has to reach the brain, means it has to be lipid soluble. But at the same time, it is also protein bound, which leads to hypersensitivity reaction. And whether it is phenytoin or other antiepileptic drugs like phenobarbital or whether it is carbamazepine, all of them blindly you can write down they have enzyme inducing property. It can produce lots of drug interactions. Phenytoin also shows zero order kinetics. We only have three drugs, three chemicals, phenytoin, aspirin, and ethanol. These three chemicals exhibit zero order kinetics at high dose. Coming to the adverse effect, there are 6 H in adverse effect of phenytoin. Hypertrophy or hyperplasia of gums, hypersensitivity reaction because of high plasma protein binding, and hirsutism, which means lots of hair growth. This hypertrophy and hyperplasia of the gum is because of consumption of drugs like phenyltoin. When the gums tend to enlarge like this, the food particles tends to go inside the gum, leading to halitosis, bad breath, or even dental caries, and ultimately leading to severe infection of the mouth. It also leads to hyperglycemia due to decreased insulin release. It leads to hypocalcemia because of decreased absorption of calcium, and also leads to phenylphthalate syndrome, which includes cleft lip and palate. So these are the 6 H which makes phenyltoin more important from adverse effect point of view rather than the mechanism of action. Other adverse effects of phenyltoin are it leads to megaloblastic anemia and also osteomalacia. But the adverse effect does not end there. It also exhibits CNS adverse effect. Definitely, as it can cross blood-brain barrier, it can reach the brain. If it can produce some action in the brain, it can also produce adverse effect. Any drug that decreases the activity in the brain will produce dizziness, drowsiness, loss of consciousness, tremors, ataxia, psychological disturbances. Whether it is antiepileptic drugs, whether it is alcohol, or whether it is sedative and hypnotics, name it, any drug that crosses the blood-brain barrier, can reach the brain, will produce these adverse effects. It also produces GI toxicity like nausea, vomiting, and serious toxicity like hypotension and cardiac arrhythmia. And why not cardiac arrhythmia if it has the same mechanism of action? The first sentence of cardiac arrhythmic drugs is all antiarrhythmic drugs are proarrhythmic. So if this drug can act on the brain, and by cross reactivity, if it happens to act on the heart also, then this can produce arrhythmia. That is why we have the safer form of phenyltoin. The phenyltoin is used for generalized seizure, partial seizure, status epilepticus, as well as trigeminal neuralgia. Then we have fosphenytoin, which is a prodrug, but this fosphenytoin is less cardiotoxic than phenyltoin. Then we move on to the next drug, that is carbamazepine. The mechanism of action of carbamazepine is similar to that of phenyltoin. That is, it prolongs the inactivated state of sodium channel. Like phenyltoin, it also has cytochrome P450 inducing capacity. In fact, it can enhance the metabolism of itself. That is why its half-life varies. Initially, when you take few first doses of the drug, half-life is 25 to 60 hours. But if the patient consumes for 5 days, 7 days, 10 days, then the half-life of this drug tends to decrease to 10 hours. This is because it enhances its own metabolism. And at the same time, it enhances the metabolism of other drugs as well. Like phenyltoin, it also has plasma protein binding capacity, leads to adverse effects like hypersensitivity reaction, skin rash, exfoliative dermatitis, hepatitis. And just like phenyltoin or any other drugs, if it can cross blood-brain barrier, it can produce action in the brain, it can produce CNS toxicity like dizziness, drowsiness, ataxia, psychological disturbances, and so on. Like phenytoin, it is also used for management of various epilepsies, but it remains a drug of choice for trigeminal neuralgia. Because of its cytochrome P450 inducing ability, it has multiple drug interaction with other drugs like warfarin, phenytoin, and theophylline. That is why we have the safer form of carbamazepine, that is oxcarbazepine, which is lot safer because of its less ability to induce cytochrome P450. So with this, we'll end our topic for today. We'll start our class day after tomorrow. Have you been informed regarding the change in schedule of the class?
Yes, sir.
Anatomy will be taking in the morning, Vanera.
Yes, sir.
Okay then. So then we shall meet day after tomorrow. Thank you for having patience.